Well, how are y'all?
Hi.
Oh,
Hey, can I jump in and ask the first question? We just kick this
Go.
party off.
yep.
Go.
Cool. Um, Follow up from last week on trigeminal neuralgia. Where does the grounding pad go?
I just put it on the top of their hand,
Okay,
just so it's
doesn't matter
close.
which. Is it this
Nope.
like ipsilateral side? Doesn't matter.
Doesn't matter at all.
Okay, cool. Other thing, I find that when I'm trying to go for femoral nerve, I'm getting a lot of contraction of the adductors, like adductor magnus. Is that pretty on par, like, or should it be straight up quad?
I mean, if you're out, I'm not looking at the quad. I'm not looking for contraction so much. I'm looking for the distribution of the therapy. And as long as you're
Okay.
feeling it going down, sometimes it'll break off. Sometimes it'll go more medially to the inner thigh, and then
Yeah.
you kind of want it to go straight. But if you feel it traveling down, you're good. You're proximal to it.
Okay, cool. Yeah, because the guy that I was talking about with like the lumbar stenosis and like the paresthesias down the entire lateral leg, you had mentioned like try to go for femoral nerve. And so I did, and like I get it to where he's able to sense it down the lateral part of his thigh. So I assume that's like the most important part, right?
Yep. With
Okay.
him, obviously.
Yeah. Yeah, yeah. Cool.
Like I had this patient earlier in the week who was like, he was a paratrooper, like parallel to Vietnam War, complete atrophy of both of his legs. Like he's like all willing to do everything. He's wheelchair bound, but he can get up.
Mm,
And he was like beyond happy that it like so it's like the bizarre thing is the tone issue. The tone issue is real for everything. It's tone for the nerves in your legs. It's tone for the pelvic floor, for everything. It's tone. And like we're the only ones that can change tone. I know that sounds like Twilight Zone crazy stuff, but it's not. It's real. And like
mm-hmm.
this guy could get up and walk when he was like wheelchair bound. Like I have a video that I'm gonna put out. I treated a guy earlier this week with MS who had complete drop foot, and he's like 43 years old. And I just put the video on Facebook and couldn't lift his leg at all. Treated him, and he's like jumping around like crazy. Like he's like, I can't do this. And he's barefoot, jumping around and just doing his thing. And I was like, fantastic. And that's purely tone, you know? So that's what I would look for that guy.
Yeah.
Michelle, what's happening with you?
Um, nothing really new. Just trucking along.
Cool. Anthony, what's happening with you?
I'm trying to get out of the house right now, but
I
my
can't help
girl
you
that
with
we
that.
talked about last week, um, she's very excited. She's regaining use and function of her hand, which we haven't really seen much movement on in like a few months, maybe a little bit, like real kind of not a ton of improvement until now. Um, she's really tired between treatments. She's Um, and just to recap, this is the girl that had the cervical artery dissection with left-sided sensory deficit, upper and lower extremities, and right-sided muscle myotome weakness. And we've been kind of going 3 minutes per nerve, starting with the brachial plexus and moving down to how much she can tolerate. And it's been working great. Super excited. Got a couple of neuropathy patients that one drug-induced neuropathy patient I was treating last night um, came in and probably 7, 8 out of 10 pain with her hands, and she left feeling great. She had sensation in her pinky, in her fifth finger that she hadn't had in a very long time. I'm, I'm very impressed, very excited.
Nice.
And I'm very Let me see. And I'm very appreciative for the assistance and like the protocols. I'm taking it to work. I'm on my way
Well,
out the
that's what
door.
we're here for, to try to help people.
Yeah, exactly. Very appreciative.
Cool. Nicole, what's happening in Newport?
Um, we are seeing really fun, exciting results with the STEM pod, definitely. And I have a couple of cases. I've got a trigeminal neuralgia and a Bell's palsy that I'm treating that I just started treating. I'm definitely interested. I have a few questions regarding those cases. So whenever it's question time,
It's
Go
question
right,
time.
go
I'm
right
ready.
ahead.
Okay. All right. So, um, I think I have a little bit of a lack of clarity around um, the aspect of treating like the motor areas. Like I understand the concept of put it on the peripheral nerve where it's most peripheral, and it's going to have an effect everywhere where the nerve travels. I understand that concept, so I think we're getting good results by just using that concept. I think where I have some lack of clarity, I'd love some more clarity, is when we put the stem pod pin other places, how long, that kind of stuff. Because I've learned that you can put it on painful areas. Um, like yesterday, I had a patient who had an upper trap spasm, and so I treated her brachial plexus because she also had, I think it was partially she had a positive upper limb tension test on that side as well for her median and her ulnar nerve. So I treated brachial plexus to help that, but then she still had some spasming in her upper trap. So then I took the pin and I put some gel and I moved it till I found a spot where there was like a little bit of muscle contraction, and I left it on there for like 30 seconds, just moved it around a little bit, and then I moved it and it seemed to help the spasm, but I don't know if I did that right. So so that's like three questions in one, but I would like clarity around using it not on specifically on a peripheral nerve.
So
Um,
you can use you can use Stimpod on any point of pain, like if it's ligamentous, you can use it on trigger points. It doesn't really matter. When you're treating peripheral points, I generally do 3 minutes at a time and then test it afterwards. Whether it's if it's like tennis elbow, I'll give them a weight and make them swing. Like depending upon I'll stress test everybody and then see where the pain is subsequent to that. If it's gone, great, then we're good. But like trigger points, you can just put it directly on the trigger point and it'll cause that to dissipate for the most part. Um, in reference to the face, again, I'm not doing 5 minutes on the nerves in the face. Is it more Bell's palsy or trigeminal neuralgia?
I have two different patients. So let's talk about the Bell's palsy, for example. What I did for
What
her is
what's
I
affected
put,
in
oh, what's
what's
affected?
affected in
Her left, it's on her left side. Her left eye cannot fully close. She cannot fully purse her lips on the left side. It can't close. Um, and she's having trouble with pronouncing some words. Her tongue, though, she can roll her tongue on the roof of her mouth, but when I checked her palate, it doesn't move. Um, when she goes ah, I put my finger on her palate and had her go ah, and it didn't move. And
so you can
she,
all right, so
yeah,
that's like many different things that you're talking about. So does she have any underlying disease state or
no, it came on it came on the December 15th.
wow.
And then she also has optic nerve affected because I did a full neurological, eval on her. And so she's having convergence issue. Like when the pen gets to right about here, her left eye just goes out that way. It's like she can converge until right about here, and then her left eye literally just pieces out and goes to the left. Um, And then she also is having trouble with reading both eyes actually, but the left is she can't really read at all with her left eye. Like holding something just at arm's length that she should be able to read. Her right eye she can read. With both eyes she's better than just the right, but not much. And her left she like really it's super blurry. She can't. So
So my guesstimate would be she's very high with Stimpod, like 0.2 and a lot. Is that what's happening with her?
I
Like
wasn't
what?
sure what to do, so I did point one. And what I've done so far is I did basically one treatment. So I did point one and I put the pin right on, um, like right in front of the ear where I think it's the most the facial nerve is the most superficial.
All right,
And I did that for 5 minutes at a point where I could see like a little pulse and she could feel but I had her turned up, I think it was like to like 20, probably 20. Um and then on the intensity. And I did the other side as well. And I did the trigeminal nerve too, just because I was like, not sure how to do the things with the muscle and the trigger points. And so I was just like, let's just try to get some better
all right,
sensation to her face. And I did vagus
all right.
nerve on the
So
left.
I'm just
So
gonna
that's
here. So when you're dealing with the eye, you're gonna want to put it at the medial eyebrow, right above the medial eyebrow, right below the lacrimal duct in the corner of the eye, to the
okay.
eyelid. When this is
Okay.
on, make her start blinking.
While it's on,
Tell her
make
to
her start
blink.
blinking. Okay.
Yeah, her eye's gonna close completely, but you're gonna be going high, like 0.2 and close to 30. I treated a woman who hadn't closed her eye for months, months and months, and it was surgically induced, right? Had it like 0.2 and 30, her eye completely closed immediately and like stayed
Oh,
closed.
okay.
So it was high, like high.
Okay.
And if you're going really high up there, just think about putting the ground pad like on the medial forehead, because you're not going to want to put it on her hand. She's not going to be able to tolerate it, and her hands will be jumping.
Okay.
So think of so you're going to put it here, then treat here and treat here, and then for the mouth you go to go, she probably has this also. So it's like
Yeah.
the right at
Droopy.
her cheek goes into her nose. Drop it down. It's going to go into her upper lip and drop it down to the mandible. And it's going to go like that also. Is that slightly clear?
It is.
Just look at the.
Yeah. So the ground pad, right above the eyebrow, and use maybe one of the small ones.
Yeah. Use the
Yeah.
small one, because
Okay.
my anticipation is you're going to be close to 0.2 and 30. Her eye going to
Okay.
close. So you
Okay.
always turn it up until it's a pinch,
Always
and then
turn it
you
up
drop it
until
back
there's a
down to a
pinch.
tap. She'll probably never. Yeah, she's probably never pinching. Um, so that's you're going to see motor response with that for sure. Um, and with the trigeminal neuralgia, like whatever she can't do for the Bell's palsy, make her do it. Like make her purse her lips, make her puff her cheeks out. Like do the things
Yep.
that she cannot do
She
while
cannot
we're
do.
doing it.
Okay.
You can also put this on her soft palate of her mouth, with no problem, no gel, because it's going to be conducting. Don't worry about that. So you can put it anywhere in her mouth.
Okay. And then as far as timing goes, you said three
So,
minutes.
yeah,
So
3 minutes. You're gonna be
three
at a
minutes.
bunch of points for 3 minutes.
Okay. Each 3 minutes. Okay. And then one thing just for clarity, you said put the ground pad here. Um, are we also treating with the pen there above the
You're
eyebrows
not gonna really have to do that. I
because the
wouldn't
ground
bother
pad's
doing that
there?
after that. Yeah, the ground pads,
Okay.
it's gonna be hammering that even more all the
Okay.
time. I'm just
Okay.
trying to get the conduction going so she's not spasming him out, her hand's not jumping. We're not
Yeah.
creating something else with the ground pad.
Yes.
Uh,
Makes
and
sense.
and then with the trigeminal neuralgia, if it's true trigeminal, go to trigeminal. But if it's not, just go to wherever the pain is and just put it on it.
Okay. Yeah, so that's great, a great point. Is this being recorded, by the way?
Yeah, I'll send it to
Good.
you.
Okay. All right. So for the trigeminal neuralgia, this one's is complicated. So I would love advice. So, uh, she's got burning on her left. It's a different patient. She's got burning. It's been about 6 months. It started after an oral surgery, and she's got burning her left uh, top molar towards the front, and her tongue is burning on the left side. She cannot taste anything, and her smell is affected on the left side. She can smell fine through the right, but not the left. Um, and let's see, not she actually has numbness on the right side of her face. The surgery was on the left, and I tested with sensory, and she her 2 point discrimination is not good on the left on the right side, but just along the jaw. And then her left side 2 point discrimination's fine. Her main thing is she wants to taste, she wants to smell, and she wants the burning to go away.
So, you can do through her face to where that pain is in that molar.
Uh-huh.
That works. It works for tooth pain all the time. I have not been successful yet with burning mouth syndrome. I only had one patient. And we were putting it on her tongue. Um, we were having them do vagal stimulation,
Mm-hmm.
and she thought hers was chemically induced and not mechanically induced like yours is going to be.
Mm-hmm.
So I would kind of first think about the original trauma of that surgery where she had the surgery. Like think of it as like I'm literally just spitballing. You're not going to
Yep.
hurt her by doing anything, but if you can find the original source of the trauma where the tooth was and
Mm-hmm.
uh, and do vagal stim, um, I would probably start there.
Yeah. Okay. So the you would put the pen right over the
Uh,
gum area, right over the gum area where the tooth is for 3 minutes. Would you do three?
you can put it right over the face, over
Oh,
her cheek.
oh,
It'll go
right
right
on
in.
her cheek. So you don't have to go inside. You can just put it
You
on the
can,
lip.
you can. It's not a problem, but it'll go right through the face.
Yeah. Okay. All right. So put it there. And for 3 minutes, would you do 3 minutes with that?
Yep.
And
Yep.
then
And then I
would
would think about vagal stimulation because this one trauma created this cascade effect on her.
it did, yeah. It definitely like her symptoms sort of like piled on too. It wasn't just like all of them all at once. So definitely there's that. So I'm thinking of her case in terms of there was an initial thing where there was the burning on the tooth. I'd have to look back because I don't remember when all the other symptoms started, but like the right side, definitely problems there started much later. Um, and the burning the tongue was not immediate. It started a little later. And I think, she told me she was freaking out about the burning above her tooth after the surgery, and she was very stressed about it. She definitely has autonomic dysfunction now. She went into massive spiral. She was actually in a hospital with psych, over this at a certain point.
So,
So
so I'm like hearing like CRPS or RSD just like locally in her
hmm
mouth because
hmm
that's what it sounds like.
hmm
So I would just do vagal stim with her first for 5 minutes. You could do for 10 minutes. And then
hmm
you can literally have her put the pen inside of her mouth exactly where the original trauma was, and that's it. This is not going to be super high.
Keep it
Like this
low.
isn't going to be like that. Yeah, like, but you still want to get it from a tap to a pinch to a tap. That's the same protocol for everything.
Okay, so you
So
go to did you say a tap to a pinch?
yeah, so you turn it every protocol is the level for each individual nerve is you go from a tap, bring it up till it feels uncomfortable or a pinch, and then drop it back down to comfortable. So if we're pinching at 20, confirm it's comfortable at 18, and then just walk away because
hmm
that's what that nerve needs.
Yeah. And so is there going to be a tap if we're treating the tooth?
Yeah.
You'll see a little pulse.
No, she's gonna feel it in the nerve, like for
Oh, she'll
sure.
feel a tap. She'll feel a little tap feeling. Okay,
Yeah.
got it.
But I would just be conservative with her to start because she has so many symptoms and it's like chasing them doesn't usually help.
Yeah, that makes sense. All right, I'll try that. I see her today, so
So mellow her out
yeah,
first.
yeah.
She's gonna be terrified. Trust me.
Oh, yeah, I've treated her twice now. I did the Vegas. She loved the Vegas. And because she was terrified. So the first treatment with it, only did Vegas, and that was good. She was happy. She felt more calm. She said she yawned for the first time, like, in months, and she was happy about that, really happy. Um, and then the next treatment we did vagal stem, and I did trigeminal. I did above the eyebrow. I did right on the cheek here, and I did on the chin for 3 minutes. Yeah, I think I did 3 minutes each. 2 minutes. I think it was 2 minutes each, actually. And I did really low.
So like honestly, I would just do through her face on that molar
Yep,
or that
I got
tooth
it.
that was affected. Just do it
Yep,
through her face to start.
yep.
And don't worry about turning it up. It'll be fine.
Yeah. Okay, that gives me some good. So you said CRPS presentation. If someone has that, what's the protocol for that? Like if it's in their leg or their arm,
So you chill them out first doing vagal stim, and then you go to the original trauma,
and you put it on
whatever
that.
it is,
So if it's their
that
knee,
trauma.
if it's their knee,
Put it
then
on
it's
exactly where the trauma is.
where the worst pain is. So
Like,
yeah.
no, the initial pain.
Oh, I see
Like
the
day
where the
one,
trauma
this
was.
is what happened.
So what have I got? Because I
Yeah.
do have a
Whether
patient. Oh, go ahead. Go ahead.
I'm done.
Oh, I have a patient who got
I
hit by
said
a
I'm done.
train. He's got hit by a train and he's got CRPS in his right leg. So he had like fractured femur. His lower leg got you know completely shattered. Um, and so he's got lots of pain in that whole leg. And he's been diagnosed with CRPS. I haven't valved him yet, but he's potentially going to be a patient. Um, so yeah, so it would be basically like the shin, since that got shattered, and the femur, maybe would be the two.
Yeah. Yeah. So like with those, if it's just in that leg, it's not CRPS, you know. If it's in bilateral legs or upper extremities, then you got CRPS. Otherwise, it's just a diagnosis of it. Um,
So I'll have to
but
evaluate
if it
that and see what he actually
because it
has.
sounds
But
like if it's just local trauma, then it's local trauma,
yeah.
you know. So do the vagal stim and then treat whatever the original site of the injury is or whatever neuropathic symptom it is. But it might not, unless he's presenting with bilateral. Like my first CRPS patient sprained his ankle as an engineer walking on a site, and then I see him 2 years later, and it's like 13 surgeries later, he has bilateral upper and lower extremity neuropathy,
Hmm.
and he can't wear shoes from a sprained ankle.
Right. And so you
So
put it on the original site of the ankle. You put it on the
I,
ankle.
yeah, like I've chased CRPS before, and it wasn't good. It blew him out and inflamed him.
Great. I'll send you the recording, Nicole.
Cool. Yeah, thanks for all that. It's helpful.
Great. Julian, what's happening down south?
Hey, what's happening? Going along with Crips, how long do you keep it in that spot? Just the 2, 3 minutes, or are you doing 5 minutes on the original site?
You could do
With the-
5 minutes if it's going to be a couple spots. It all depends on the site of the injury. If it's like an exact spot, just cover it over a few minutes. Like the
Okay.
original trauma is, say the original trauma is like 3 inches long, go like 3 minutes, 3 minutes, 3 minutes, and then we're done.
Okay. And how long, roughly, how many sessions typically is there? I mean, that's a weird diagnosis,
So,
but
so, so the whole thing is this is self-induced. It's a sympathetic response. So you have to chill them out. Like, so it's like I've gotten results first visit many times.
okay.
And then like if they don't do the self-care stuff, like if they don't start breathing and you start doing vagal stimulation, it's going to immediately come back upon anything touching it. It's
Mhm.
going to flare them up and freak them out, and they're going to be in the exact same spot. And it's like they have to actually change the way they're presenting and holding themselves. And that's a
Yeah,
hard thing to crack.
sure. That's why the vagus nerve would be a big one for them.
And I've gotten people completely out of pain and they rejected it with CRPS, rejected therapy immediately because they're
Really?
victims to everyone in their world. Like
Mhm.
literally they're victims. And that's like Twilight Zone for me the first time I saw it, but it's real.
Right. Right. Oh, okay. How about any strength tents? I have a guy with cervical radiculopathy or left upper extremity radiculopathy. Pain's been reducing with cervical traction. That's doing better. We just got the Stimpod and started trying it on him. How long do you see changes in strength? Like his primary complaint now is strength.
So how old is the guy and is there atrophy?
No, 38 years old.
So he's fine.
No atrophy. Yeah.
Great. So like you can like so whatever the radiculopathy, whatever corresponding fingers on that side, treat at the brachial plexus, have it go down the entire arm, and
Mhm.
then give them weights immediately thereafter and start working them out. Like
Yeah. Okay.
right then, like
All right.
immediately.
Immediately. Okay. Cool. Had one guy that has neuropathy, treated his neuropathy. He felt better, not a big change, but right then and there. But then he complained of increased pain the next couple days. What could I have done different, or is that
It all depends on what
happen?
his
Or
neuropathy. No, it all depends on what his neuropathy is, how long has he had it. So like occasionally, very rarely a patient presents like that, and it's like the peeling the onion away, you know? Like now it's not complete paresthesia. Now we're starting to feel other things that are there, but it was complete paresthesia before. Now I have a little bit of pain where I didn't feel anything before. And like I've had patients like I had a patient that said that and he's like, I'm not gonna do it. I'll just take the paresthesia. I don't want to go through the pain to get to the other side of that.
yeah. Yeah, this guy's a 48-year-old diabetic. Um, Plumber is on his feet all day long, complains of pain. We've been treating him for quite a while with shockwave to his feet. That was the only thing that gave him relief. But it's only like a lasting like a week. It's just managing. It's not treating or not getting rid of it. Of course, super fit. Diet's under control. All that stuff. So I thought, let's try this on him. I just did his second treatment. I need to call him and see how he's doing now. But
Yeah, just see how it is. I imagine he'll succeed. I imagine he'll be good.
oh, cool. Thank you.
No problem.
Who else has a question or comment?
I guess quick thing. I was watching one of those videos. Was it Dr. Huey or something out of Ontario or Canada? He was largely placing the pad on the opposite side. From talking to you, Stan, and Kieran, I believe you guys put the grounding pad on the same side.
So like
Thought between one or the other.
so the company's official line is put it on the opposite side all the time. But if I know the endpoint of a nerve
Yeah.
and you can do this on yourself, it's the connection's much better when you know where the endpoint is. Like I'll give you an example. I treated a woman who had severe intercostal neuritis where she was freaking out. Like she's had it for years, right? And I adjusted her rib heads back in and we were treating posteriorly. And I had the ground pad. I was looking for the distribution of the nerves going to the anterior portion of on that rib. I put the ground pad, so then we take the pen and we put it exactly where she's feeling it anteriorly and put the ground pad in the back. And she's like, all right, now I feel it wrapping completely around my back. If I didn't do that, that would have never have done that.
Right. Okay.
So,
So grounding
so
pad along the line of the nerve
yeah.
versus
So if
opposite
you
side.
know it, it's helpful. But if you don't know it, so like if you're treating the brachial plexus, right,
Mhm.
and you're treating it when you switch that ground pad between your thumb, your middle finger, and your pinky, you're going to be picking up those nerves specifically. You're never moving this pen, and that
Mm.
connects that ground pad to those nerves.
Oh,
That's not how the
interesting.
company teaches it.
Okay.
I'm just doing it from my practical experience.
Sure. Sure. Okay. Interesting. Okay. I'll have to test that, but on myself.
Yeah,
Just
Yeah,
change that ground
never
pad.
move the
Yeah.
pen. Never
Keep
move
the
the
pen in
pen, and
one
you're gonna.
spot, move the pad.
Yep,
right.
and
All
like
right.
it changes the conduction of each of those nerves. It picks it up, so it
Cool.
facilitates the conduction along that nerve.
All right.
And there
Well,
are a few times when, for instance, if you're doing carpal tunnel at the wrist, a lot of times if you put the pad here, it's just too close and you can't get as much power as you can if you put the pad contralateral. And if you do the ulnar here, you can actually get a lot more power with still being comfortable for the patient. Or there could be instance where metal, again, if they've had surgery
yeah.
and they've got metal, hey, we don't have to be right there. You can be here or you can be at the brachial plexus. But I think if you play with the brachial plexus and just put small pad here, you'll isolate the ulnar, move the pad over to here, you'll isolate the median, move the pad over to here, you'll isolate the radial. And so that's
Okay.
how, yeah,
And the goal is to take it up as high as they can tolerate without
Yep,
the pinching, just down from the
correct,
pinch.
yeah,
correct.
it's always, I explain it as most of these patients are coming to you because of pain or discomfort. We're not trying to inflict any additional pain or discomfort, but for the 3 minutes or the 5 minutes that we're treating that nerve, we want to give them the benefit of the maximum amount of stim pod energy we can without it hurting. So find your location, crank it up until you've gone a little too far, and then crank it back down a little bit. Make sure it's comfortable. And then for them, that's the maximum therapeutic dose that they can tolerate today. But keep in mind, same patient, same nerve, different day can be different.
Sure. Cool.
Great. Anybody else?
I have a quick question about wound bed healing, putting the probe on the perimeter on the intact skin or border of the wound versus it on a superficial open wound bed.
I
If you
honestly haven't done that. I have not done that, so I can't attest to it. So I I haven't done it. I'm not going to say
Yeah.
anything.
It is one of the
I
listed
think you've done it more than us.
contraindications in the corporate material is not to put it on an open wound.
Yeah.
But around the periphery, I think it could really help, reduce the pain for them. I just wouldn't go in the open wound.
I
I
mean,
mean,
the philosophical.
I've been
I
using
think
it on the
philosophically
perimeter. I
works.
feel like it's helping, but
Yep.
I've just been using
You
it on
said,
the
but you
intact.
said you used it so far with this, correct?
Yeah, and I think it helps with epithelialization inward from that. So I do the border if I can, just the intact skin around the wounds. And I feel like it's helping, but I don't have a real way to compare because um I don't. So, but I feel like it does help, but I've been using it on the periphery. So
Great. Anybody else?
I have a quick question, a general question. Is there a
Sure.
place we can go to see all the past um, videos on YouTube, or is there
I'm going to.
another
That's
place?
why if everybody makes sure they subscribe to my new YouTube channel, that's where instead of just sending out today's replay to you next week and then you've got to archive them, all of them will be on that new YouTube channel. So look in the reminder you got yesterday because I keep putting the new YouTube sign up link in there. And so that's where we will be archiving all of these replays.
Okay, so if we subscribe, then eventually, once that's in place, then we'll have access to all of
Correct.
those.
Correct.
And is it
And
going to
that's
say
actually
is it going to say what topic it was so that we
I'll
can?
I'll
Okay,
get AI to go in and do a little, 1 sentence or 2 sentence summary of the content of it and title it. Yep.
okay, that would be really helpful.
Yep.
Yes.
Cool. Okay. If anybody else, last chance.
I have a quick one. Neuropathy, bilateral neuropathy. Is it multiple types of treatments, or do you guys have a kind of a shotgun? Because I know there's multiple reasons why someone can have um, neuropathy, just both feet, for example. So I have some ideas around how I could logically decide how to use it, but I want to hear from you guys
So
about
make it
that.
real quick. You use the big ground pad underneath the toes. You
Okay.
treat common peroneal nerve behind the fibular head, and you treat posterior tibial at the ankle.
Mm-hmm.
And then if it's on top of the foot, you move the ground pad on top of the toes, and you treat the dorsolateral cutaneous nerve, which is halfway down the shaft of the tibia, laterally. All right. Just do it to yourself, just so
Okay.
you can feel that one. That's the only one. You only do that if they represent with the sock-like expressions on top of my feet
Uh-huh.
and the bottom of my feet.
Got it.
But that's only like that's not a huge portion. Like 70% is just bottom. So
Okay.
that's just common peroneal and posterior tibial.
And
Okay.
then if it is a diabetic induced neuropathy patient, you really want to have that heart-to-heart nutrition discussion with them, because if they're not willing to help manage the underlying blood sugar, it's like, we're kind of wasting everybody's time, because
Yeah.
we really can help their nerves. But if they're continuing to cause the problem unabated, it's like, why? So
Yeah.
just have
Totally.
that discussion with them.
Okay. Thanks.
Cool.
Stan, I have one last question if I can.
Sure.
Yep. Last week we were talking about restless leg syndrome, and I had two different theories on this. Am I putting the pad on the foot, or am I putting the pad up on S2 and treating it like a pelvic disorder? I kind of got a little confused there, like incontinence.
So I would put it on the foot because we're
Okay.
treating the foot. It's not going to be an incontinence thing. And to me, it's more of a vagal stim thing. I would do both. Treat like the nerves. So if it's the whole leg is jumping, if it's not just their foot and their lower leg, it's their foot and lower leg, treat common peroneal and posterior tibial. Great. If it's their whole leg is jumping, look at femoral also, and then do vagal stim on the involved side.
Got it. And if they're,
I
I
think
mean,
if
on both
vagal,
legs, do
if it's
both
both,
legs if it's, yeah.
do both legs, but like I would just think about, do both, calm them down, then do vagal stim in the end, just to cover your ass in reference to that. Because to me, I've had people tell me that they did the legs. I honestly, philosophically, don't really believe that it's a leg thing. I think it's a brain thing. So I'm more inclined to say that, but other people have told me that it worked great for them. I haven't treated it like that, and but that's that.
I started off because I'm new to the pod. I thought, hey, you're kind of like a guinea pig for me. I'm going to just do your left leg. Left leg got great. I wasn't touching your right leg. And then when she that was improving, it's okay. Well, let's do both legs now. Now we're doing both legs, and the left leg's coming back. So I'm a little bit confused on that on what to do. So I will treat it with common peroneal because it is the whole leg, common peroneal, tibial, and femoral,
Femoral.
and I will heavily focus on or I'll increase the Vegas to what 5-10 minutes.
No, I mean, I would do 10 minutes at the end and just let them sit there, so they're leaving on a nice calm note, and like
Okay.
you put input to the legs, so then you're just gonna finish off with their brain, and
Okay. So
that's
three
how I
minutes a
would do it.
spot, 3 minutes a spot in the leg, and then 10 minutes on the
Yeah,
Vegas. Got it. Okay, thank you.
correct.
Right.
No worries.
All right, everybody. We will see you all same time next week.
Thank you.
Thanks,
Have a
everybody.
good day.
Thank you, everyone.
Bye.